Tell you what I told them when they just flatly asked my opinion about the product. As far as trauma vascular surgery, this is going to be it's going to revolutionize the field.
You're going to hear from 3 investigators, all of whom participated in our V005 clinical trial, evaluating the safety and the efficacy of Humacyte's bioengineered vessel in the treatment of patients with traumatic vascular injury. The first surgeon you'll hear from is Dr. Ying Wei Lum. He is a surgeon at Johns Hopkins School of Medicine and has treated a number of patients having both acute community-acquired traumatic injury and also traumatic injury that was associated with the treatment of tumor resection in some patients at Hopkins.
So some key takeaways that I thought were nice to summarize in this case. This was graft was implanted in a, not a typical traumatic case, but a iatrogenic case where some form of vascular reconstruction was deemed necessary, but the saphenous vein was not available or not ideal. Patient was considered high risk for infection due to radiation and congestion from the venous drainage. At the end of the day, the patient had a graft that remained patent without any complications. And I think the last and key thing is to note is that this is pretty easily available off the shelf. You don't have to wait to thaw it for 30 minutes and do a bunch of fancy flushings and time-consuming things to thaw the graft out. It's got excellent outcomes, at least in my experience, for these kinds of cases when autologous vein is not available. I think the benefit of this over that saphenous vein as well as the size reconstruction. And as Dr. Kundi and Dr. Fox have talked about, the ability to resist infection, I think, is pretty paramount over here. You could put it in infected fields and they seem to do pretty well. So I think, although the indication is for trauma, I do think that a lot of people will be using it for all sorts of other reconstructions whenever infection or size is a consideration. I don't think this will overnight replace saphenous vein. That's probably not the goal of the graft. But I do think that, for at least all the complex reconstructions I do, I probably use it almost all of them. I don't think it will replace all saphenous vein grafts as standard of care. I think where it may replace is prosthetic grafts. I think this is more likely to replace prosthetic grafts than saphenous vein grafts in general. And depending on what size, right now there's only a 6mm size for Humacyte, but depending on what sizes come up in the future, I think the expandability and the length of the graft it can impact replacement for almost all the prosthetic grafts in the future, I think.
Next, you'll hear from Dr. Charles Fox, who's at the University of Maryland School of Medicine and is also a retired U.S. Army Lieutenant Colonel. Dr. Fox works at Baltimore Shock Trauma and will be presenting a case of a patient who was cared for in Ukraine during a humanitarian effort that Humacyte undertook in cooperation with the Ukrainian government after the Russian invasion of that country.
The ATEV conduit was a 3-centimeter conduit which was interposed into the common femoral artery because of a lack of any saphenous conduit. As you can see, there's so much extensive soft tissue damage that we really need another option that comes off the shelf, especially to expedite the operation and to satisfy the reconstruction when there isn't another option. In a military conflict, that's a very small niche of commercialized patients. But anytime I'm worried about infection or speed of the operation, I think of alternatives to harvesting the saphenous vein. The saphenous vein is obviously our go-to conduit, but many times time doesn't permit, or the injury doesn't permit, or the infected field might be a consideration for some alternative. And I personally don't think there's any other alternatives to the ATEV right now. This doesn't require much preparation. You basically cut it out of the plastic tubing and you flush it and you begin sewing with it. And it's got great handling properties. So it's a very fast opportunity to begin your bypass with minimal aggravations. And when time is of the essence, this is really important. Or when education level is of the essence, it's very important because many general surgeons don't always feel comfortable harvesting the saphenous vein and then embarking onto a difficult bypass operation. It just becomes a bridge too far. So this allows us to do something that's given very good results and seems to be remodeling into the artery and resisting infection. So I think it's going to be my go-to conduit in those situations. Thanks. I also anticipate using it in the future for dialysis access. A number of the dialysis patients that I treat don't have any vein anymore. They sort of have used up the available vein in their upper arm, and the lower arms in my patient population on the East Coast is pretty non-existent, especially with diabetes and renal failure combined. So given its opportunity to resist infection, remodel, and be a very easy conduit for handling, I think there's going to be a lot of dialysis access surgeons that'll be interested in this. Yeah, well, I think this product really meets the needs of a wartime injury because of the risk of infection, the need to have an off-the-shelf option, and the lack of saphenous vein.
Lastly, we'll hear from Dr. Rishi Kundi, who's also at the University of Maryland School of Medicine. He's a vascular and trauma surgeon, and he will present an expanded access case. This is a trauma patient who sustained his injuries after the closing of enrollment of our V005 clinical trial, but who in fact suffered multiple complications with previous attempted revascularizations, and who received the Humacyte's engineered vessel as part of an expanded access or compassionate use program.
As you can probably tell by how I'm dressed, I'm on vacation right now. And the fact that I wanted to do this while on vacation should be some indication of my enthusiasm for ATEV. If we had simply resected the infected artery, the boy would have lost his leg. And so after thinking about it for some time, I contacted Humacyte and the FDA, and we made an application for a compassionate use exemption. We had just completed the trauma trial at our center, and after thinking about it for a long time, after consulting with Dr. Fox and some of my other partners, really the ATV was the only practicable way to keep this boy from losing his leg. Currently, the last that I saw him, he was getting ready for his fasciotomy incisions to be skin grafted. He was walking. The boy was going to lose his leg, and he is walking. He still needs some more reconstructive surgery for his abdomen, but this is not only as good as we could hope for, but this is a better outcome than I had in mind when I did apply for the exemption. And the really, as mentioned in the last bullet point here, the ATEV came as a 40-centimeter graft, which allowed us to make a complex reconstruction. We're not just talking about an interposition graft or even, a bypass. This was reconstruction of a fairly anatomically complex area in the leg, and it performed beautifully. And I really, like I said, could not have hoped for as good an outcome as we ended up having. After I used it in this case that I spoke about, the FDA wanted some follow-up, and I'll tell you what I told them when they just flatly asked my opinion about the product. As far as trauma vascular surgery, this is going to be, it's going to revolutionize the field. There are patients who have undergone endovascular revascularization. Very often they have had previous bypasses. They do not have veins. This isn't the 1970s. Everyone doesn't have a saphenous vein that's just waiting to be used for their fempop. And this will take the place of prosthetic, period. I think if it was up to me and this product was available, I don't think that I would use prosthetic. The number of times I would use prosthetic for a bypass case if ATEV was available would be less than 10%.